Thank you very much for joining us. We've been doing this speaker series. This is the fourth series in our 20th year. Great presentations have preceded this one, and I expect this one will be wonderful too, because we've got great speakers lined up for you. But what we've been celebrating during these quarterly presentations is our 20th year, and we're drawing towards the end of celebrating our 20th year. We've got 20 more under to come. The point of these particular presentations have been to highlight how the School of Public Health and our partners have come together to impact health in the Valley. And so we've been really fortunate to showcase how partnerships around public health make a difference. And today's presentation is no different than that. We have one of our wonderful partners, Ms. Mary Valencia, who is the clinic director for the Rio Grande State Center, will be presenting with us, and Alma Martinez, who's one of our own, member of the Salud y Vida team. She's our coordinator for education programs, and then Juliana Lopez, who is our project manager for the Salud y Vida program. And so together we're going to talk with you about the Salud y Vida program, improving diabetes management in the Rio Grande Valley. And I'm going to bookend this because we end by recognizing everyone on the Salud y Vida team, but we're going to start with that as well. This is a huge collaborative effort, tons of leadership from many of you on this call. And so we want to thank you, and we're trying to represent you well with this presentation. So one other piece before we start. So our 20th year somehow has flown by and will come to a close in December. But we're planning to have a kind of a special time to wrap up, give you feedback about the different events that we've accomplished during the 20th year. As you know, we've been doing some fundraising for student scholarships. We'll give you an update on the amount of funds that we raised, kind of just put a big bow on the 20th year. But we'll do that in January, so we can give you kind of final numbers and final account of everything. So January, we will get back together and let you know about some of the future plans for the School of Public Health and the way we will gather. So without further ado, let me go ahead and we'll move into the presentation. I just have to do quick sharing screens and moving us forward there. Can you see the screen? Can you give me a thumbs up? Everybody good? All right, thank you. Okay, so I have the, are you seeing it in, there we go, right? You're seeing it now in presentation mode. I don't know why it jumped out of that. So I really do have the privilege of presenting with these three ladies who, like many of you, just dedicate so much effort to creating, implementing, improving, evaluating, and making the magic happen in the Salud y Vida program. So we're going to talk about some of the results and present to you an overview of the program. And I mentioned that we have our clinic director from the Rio Grande State Center, Mary Valencia, Alma Martinez, and Juliana Lopez. Together we'll be presenting, so we've shared everything here. So let me tell you what you're gonna get, the information you're gonna get. We're going to cover just an overview of the program, a little bit of background on why the program and what do we do in the program. We're gonna highlight some of the program outcomes. What are we seeing in our data, looking at the population that we're serving. And then we'll be able to hear from our clinic partner, Mary Valencia. We'll talk about Salud y Vida as it exists in her clinic. What does it actually look like on the ground in her clinic? Then Alma Martinez will talk about what does Salud y Vida look like for the participant? What occurs for them? How do we support them? And then we'll wrap it up. And we are glad to, at that point, we think we'll have time to have a discussion and questions, etc. So that's our agenda. So most of you are very familiar with this, just that we are serving the Rio Grande Valley with the Salud y Vida program. And, as a reminder, this area is made up of one of the poorest metro areas in the U.S. Our median household income is significantly less than the average for the state of Texas. We are doing the Salud y Vida program in a state where Medicaid expansion did not happen. And so leaving many individuals who have health needs that are unmet, where the state is leaving those individuals uninsured without really good access to care. So there's gaps in what we have and what we're providing. Our physician to patient ratio continues to be very low. So we don't have enough providers in our region to meet the needs. And we know from the good work of the Cameron County Hispanic cohort that we have approximately 30% of our population who has diabetes and another 30% who has pre-diabetes. And this is far greater than the national averages, where we sit around 11% of the population has diabetes. Additional on that, setting the stage of why did we think that Salud y Vida would be part of the solution to the setting and the people that we want to serve. You can see that there's a number of social determinant of health factors that are creating disparities in our region, including income. And you can kind of see some of the facts there, right? That many people live below an income of $25,000 annually. People have lower educational attainment, and there is a number of health behaviors that create conditions that make diabetes uncontrolled, such as being overweight, not meeting physical activity guidelines, not meeting fruit and vegetable consumption guidelines. And so in each one of those cases, our population here locally is at worse status than the national status. I mentioned a little bit about access to care. At times we see our community clinics can have a 1-year waiting list. So again, the access, being able to get in and be provided the great service that's there, but time to wait to get in. And some of there's paperwork to get registered, and again, that physician patient ratio. And so we see as well that in our physical environment, that there are elements that are missing in that physical environment that support healthy living. So particularly amongst our low income areas, our low income communities, we see that there are gaps or problems that aren't promoting health. So there's a number of, as we look at this, right, there's a number of factors that come into play that set the stage for many people who have diabetes not managing that diabetes well. And so as we began some discussions now a decade ago, honestly, in serious work, right? We've been partnering with our clinics for a very long time, but we began thinking, what could we do together? And we are so proud of the work that happens in the clinics and the services, particularly that are the Rio Grande State Center offers and federally qualified health centers offer, because they really have this medical home model. This idea that there's both primary care and specialty care that people can access through this medical home. And then there's wraparound services, the social services, case management, the nutrition, might be diabetes self-management programs within the clinic that are helping their patients get more from the more support in order to manage their multiple conditions. And we didn't even really mention that, but our population has usually multiple conditions, not just one. And so then in 2011, then that's when this waiver was coming, and we said, we could do something together that would be different, that would be a way to address these social determinants of health, to look at the population with uncontrolled diabetes and see what we could do differently to better manage. And so DRPH offered the funding opportunity to do this work. And you can see here in the middle here where we are looking at partnering. We partnered with clinics. We knew from the various data, as well as the stories that our clinic partners were telling us, that partnering with Behavioral Health Authority would be important, that we wanted to have a community outreach component to it and have those kinds of partners in our coalition. The academic health science centers were partners, and then our health information exchange. So this group came together to start doing some serious planning, and somehow, honestly, we used to laugh that we were building the airplane as we were flying it. By September 2013, we had launched the Salud y Vida program in its state. At that point, as a chronic care management model, we built it off of an evidence-based program, and we tailored it to this broader population and a broader coalition and our population. And then in 2017, there were some state level rule changes, we'll call it, to DRPH, and it required us to do some shifting, because in our initial launch, we were able to go out to community members who were not already associated with a clinic and bring them into the fold, so to speak. But in 2017, the state changed that, and we were then focusing only on the populations within the clinics. And so we made those modifications and continued to move on. So I'm going to turn it over to Julie Lopez, and she's going to talk about the model going from our traditional model to the current model that we have in place. You are muted.
I'm so sorry. The controls disappear when I take control of the screen. Thank you so much. So this next picture that is not showing up yet. Okay, there we go. All right, thank you. So this is our Salud y Vida model. It encompasses various settings. This picture is worth 10,000 words, but I'm going to give you the 1,000 word version of this. As Dr. Reininger mentioned, the creation of the program involved a coalition of organizations that came together to create this program. And I'm going to start first with the clinic because this is where we start expanding from. We knew that we wanted to work together with the clinic partners, not having a separate program and then clinics doing a separate thing and then not working together, but that we were coordinating across multiple settings and together sharing information, informing each other about what's happening in the clinic, what's happening in the community, what's happening in the home, all to reach a goal of improving diabetes control and diabetes care for patients enrolled in this program. So prior to the program, if there were community programs, they really were working independently. If there were any outreach things happening to the home, they were working independently from what was happening in the clinic. And so we created this, as Dr. Reininger mentioned, this coalition and identifying the gaps that needed to be filled. Hear a little bit of surround noise. I'm sorry. I don't know if that's affecting anybody else. Okay. And so I want to start first with who is our focus population for this project. For sure, we know it's diabetes, but we know that clinics are providing diabetes care. So we wanted to focus on individuals who are high risk. So they're already high risk because they're diabetic, but individuals who were not being successful in managing their diabetes. And so our very first couple of years in carrying out this program, we focused on individuals whose HbA1c, and this is a measure of an individual's glucose control over a 3-month period. So we looked at individuals' HbA1c who was greater than 8 for enrollment. And then in the more recent years, we know that many individuals have multiple chronic conditions. And so while they may have their diabetes controlled, they may be struggling with a different chronic condition. And so we expanded enrollment to individuals who had diabetes controlled, but who also had diagnosed hypertension and their blood pressure screenings were high. So their blood pressure was uncontrolled. And that really is the population that we're working with. So we're working with individuals who are already not doing well with managing their chronic conditions. The enrollment takes place in the clinic, and we used to, as Dr. Reininger mentioned, we did a lot of community outreach and community enrollment, and then with changes that happened in 2017, we focused our enrollment within clinic patients. And patient navigators are embedded in the clinic setting to not only reach out to participants, but also providers, because providers are also identifying ways to help their patients better manage their diabetes. And so patient navigators identify patients through reports, through interacting with clinic staff, through referrals, and they inform clinic patients about the program and enroll them in the program. Once a participant is enrolled, the participant then kind of within the program kind of moves on to the home and community setting. But before I move to that, I also want to mention that patient navigators also play another role in the program, and that is coordinating information between the program and the clinic. It is so important to know what is happening in the clinical realm for the participant. Are they missing their appointments? Do they have an upcoming appointment? Have they picked up their medication? So patient navigators help to communicate that information whenever the program requests the information. And that is a benefit of having patient navigators embedded in the clinic, that they are both an access to the clinic, but also an access to the program. So once enrolled, participants are assigned a community health worker. And within 2 weeks of enrollment, that is our goal, a participant receives a home visit from a community health worker. During that first home visit, the focus is identifying what we know that this individual already is experiencing poor control of either diabetes or hypertension. So the goal is identifying what are the barriers assessing the behaviors, what support does the participant have? And it really is an assessment of what is happening in the participant's environment and life, and even intrinsically motivation, what is happening that is resulting in poor control of diabetes or hypertension. And that very first home visit is very MI focused, motivational interviewing focused. I failed to mention all community health workers are trained on motivational interviewing. They are certified. They've also been trained in the Diabetes Empowerment Education Program. And so they have all of these tools, and so they use their skills to help to assess the participants' place in their diabetes care, and then helping them to identify a goal that they will be working on as they continue to receive program services. Now that is the first home visit. Following that home visit, participants receive regular visits. At minimum, they receive quarterly visits from community health workers. These visits, after joining the program, are focused on assessing their diabetes, how is their HbA1c, how are they doing with monitoring. They also assess how they're doing with their health behaviors and meeting their goals that they've set in prior visits, in the first visit and other visits. They also identify barriers that are keeping the participant from either reaching their goals or implementing recommended clinical advice, right, that they've received from their provider. So the home visit itself is a very, very important component of the program. It really is where we identify what continues to be the problem, if there is one, or celebrate the success of improvement. In order to address the barriers that participants face, community health workers also have other resources that they can connect participants to. They connect participants to social workers that are Salud y Vida social workers. We know that clinics have social workers, and they are serving clinic patients. But we also know that this particular group that's enrolled is particularly experiencing other problems because they've not been able to successfully control their diabetes or hypertension. So having a program-based social work team is really important because social workers are able to do home visits and able to connect participants to other things that sometimes clinics have not been able to connect participants to. Some examples are food pantries, helping participants to resolve issues with affording rent and utilities, all of those things, advocating for participants and other community organizations to provide assistance to resolve some of these gaps is really, really important. And then another factor is that many participants face many behavioral health problems, and sometimes the behavioral health problems may not be at a level where it is a diagnosed and requires mental health treatment. And so participants kind of fall in this gap of it's not too severe to get mental health, but it is affecting their diabetes care. And so we have this other service with our partner, Tropical Texas Behavioral Health, and they provide a care manager who can also do home visits and provide behavioral health home skills. All participants are assessed through the normal mental health processes, so either through their clinic or when referred to Tropical Texas Behavioral Health. So that's in a nutshell what we're doing with enrollment and in the home setting. There are other services not listed here, like compassion funds. Mary will mention that. And then we also provide transportation assistance to medical visits and other community-based program services, because we know those are barriers too. And so as much as we want to motivate individuals to go to these things, we also need to provide the resources so that they can actually comply with those visits. Let me see. There we go. All right, so we've got some enrollment numbers, and we've distinguished here of kind of, and we've mentioned before, a change in how BizRep was managed. So in our early years from 2014 to 2017, we did a lot of community outreach and a lot of community enrollment. And the program launched in September 2013, so we only have a few enrollments in 2013. And during those years, when we identified individuals that didn't have a medical home, it was a priority of ours to connect them into a medical home because we knew that this is part of the model. We've got to do the clinical care, but then we've also got to do the community and home support. And then in late 2017, we had a slight transition that impacted our ability to do our community work. And so now we focus mainly on enrolling patients from our clinic partners. And you'll get to see our clinic partners in the last slide, but I will mention here we work with Brownsville Community Health Center, Rio Grande State Center, Su Clinica, and Hope Clinic in McAllen. So since then, we've been enrolling clinic patients, and all in all, we've enrolled 6,800 participants. And throughout these years, we have had clinic partners like Mary advocate for participants having the opportunity to repeat the program. You know, a participant who perhaps was enrolled in 2014 may be facing some challenges with controlling their diabetes in 2017. And so we have had, the opportunity for participants to re-enter the program, and we've re-enrolled 927 participants. And then more recently, we've identified that some participants need a little bit more intense follow-up. I said earlier when we were looking at the model that participants receive community health worker visits at minimum quarterly, but we're finding that sometimes the 3-month gap is perhaps too long for some participants who need more intense follow-up. And so we are currently, we've opened up that to some participants, and we've enrolled 39 participants who had left the program and then now have come back into the more intense program. So I want to share the demographics of just the first-time enrollment, not the repeat or the more intense. Participants who are first enrolled in the program, the majority are female, and the majority of our participants have an education level that is 8th grade or less. And so we know that that impacts not only literacy, but also health literacy. The majority of our participants are uninsured, and that is also the case for our clinic partners. Some of our clinic partners only serve uninsured individuals, and so that is the population we're serving. And the majority of participants are unemployed, 54% are unemployed. And lastly, participant income varies, but most participants are, because they're unemployed, there's no income, or are within the $100 to $500 a month income. So there are a lot of barriers, there are a lot of challenges with serving this population. And the program is helping to identify how we can strategically align resources. We can't resolve everything, but strategically align resources so that diabetes care for that individual can be improved. I'm going to pass this on to Dr. Reininger.
Okay, so we're going to talk a little bit about some of our outcomes. The first, I've got 2 slides that'll talk about outcomes. The first one is where we assess the Salud y Vida program effects on longitudinal A1c levels by conducting both univariable and multivariable longitudinal linear regression using the GEE model, a generalized estimating equation. And that helps us account for potential correlation between the repeated measures of the participants over time, because we have the same population. So we've got about 5,650 people in here in this particular analysis. And what we did is we categorized the participants into low exposure and high exposure. So you say, okay, how did you, what's low exposure? And so in this particular analysis, we said, okay, low exposure, because it's looking at 24 months, we said 10 or fewer encounters, and that included the DSME classes or a community health worker visit. So we said low is 10 or less, and then high is more, 11 or more. And what we see, first off, I want to point out is that the drop in both groups from the, let me go over here, from our baseline to 3 months is statistically significant. I've got another chart that will show you that, but very significant for both groups from 0 to 3 months. And then after that, what we see is the values stay low. And as you all know, being many of you are Salud y Vida partners and team members, that you want to maintain those lower levels. And so we are able, we're showing that. Now you may notice that there's a little bump up in both the high exposure and low exposure groups at 15 months. And that is an artifact of the fact that we have participants who at 12 months, once they've successfully dropped their A1c and maintained it, if it's still low at 12 months, then we're able to graduate them from the program. So then the people who are left at 15 months are individuals who need additional support because they weren't at that lower level, that below 9 level. And so we kind of have a bump up, and then we continue to work with those participants, and we see the A1Cs decrease again. So you may say, well, gosh, low exposure, 10 visits of lower exposure, that's still a lot. And it is. And we've actually done some additional analyses that we're not going to show today, where we really do have like a true low group, a medium, and a high, and you still see the same patterns, right? So the true low is a little bit higher and their rates go up, and then you've got the medium, and then the group that's most engaged has a better outcome. And there are points here where there is statistically significant improvement for that highest group compared to the low group. So let me show you one more slide here. There we go. So in this is where we have this, it's a multivariable model looking at our Salud y Vida program effects on A1c outcomes, and you can see that we adjusted for a number of factors here in this model, including age, sex, preferred language, ethnicity, etc. And so what we want to show you here is this is high versus low by month, and you can see that at month 3, 6, 9, 12, and 15, there was a statistically significant difference between the high and low group. So meaning it's that line, right? The difference there was statistically significant. So that's something that should tell us that when we can get patients to be that fully engaged, it benefits them in A1c value improvement, right? That it makes that level of a difference. We also see that age, that participants who are older than those in the lower exposure group, there was a difference by age. We see more female participants, more Spanish speakers, more married individuals. And those with lower education levels were in the high exposure group. So there were some demographic differences in who fell into the low and high groups. Right. And so now we get to turn this over to Mary Valencia to talk about what the program looks like in the clinic.
Hello, everyone. Can everyone hear me?
Yes.
Great, great. My name is Mary Valencia, and I'm the outpatient clinic director for the Rio Grande State Center. And I have been with the clinic for about 8 years now, a little over 8 years, and have been truly very lucky to be a part of this organization. The organization itself has been incredible. The history, I'm not sure how many of you know the history, but the history of this clinic has continually morphed over years, decades, so that it meets the needs of the poor in our community. Back in the 50s, it was a TB hospital, and then it actually became a low-income hospital. And after that, it became an outpatient clinic with multi-specialties in it. Around 2009, due to budget cuts, it became just a primary care clinic. And all of this has been under the venue of the state. The state of Texas runs it. So it's a state operated clinic. And I sort of came in at the time that it had just had its budget cut. So, so lucky me. But we were now just offering primary care. They had basically cut the services down to just the bare minimum. So we did have, however, still available to us pharmacy, laboratory, radiology, and then our primary care physicians. And so it was time to sort of start and see what we could do with what we had. And this clinic has historically served the poor or the uninsured and indigent population of the Rio Grande Valley. So it encompasses 4 counties. It's Cameron County, Hidalgo County, Willacy, and Starr. And we continue to offer pharmacy services, drug assistance program, women's health, because we do contract with a gynecologist. We have radiology and laboratory, and now we have psychiatry. What we've done is we've actually integrated behavioral health into our primary care setting to try to address all of the problems that are facing our population that we serve. The population tends to be a very highly complicated population because it tends to be one that has left their healthcare, unfortunately, to what they could find before they became a part of the clinic. And so many of their chronic conditions had been uncontrolled. And so when we get them, we have a lot of work to do. But we did find, excuse me, that we couldn't do it alone. We had to find partners to do it because we no longer had that multi-specialty group that the clinic had done before the budget cuts. And so we started going out to our community partners. One of the very first partners we approached was the School of Medicine. At that time was the UT Health Science Center San Antonio. That was prior to UT RGV School of Medicine. So we reached out to them because we needed access to care. We had this very large population of patients that now, due to budget cuts, we were down to 3 providers at that time. And so how to get all those patients to continue to be managed with that small population of physicians. And so the internal medicine residency program started rotating with the clinic, and that helped improve our access to care. And so when that partnership showed so much success in its first year, we started working with other organizations who could help us be able to serve our patient better and to help us attain those outcomes even quicker than we could on our own. And so one of those was the UT Health School of Public Health. And so one of the things that we did, though, very intentionally, and this was actually through a different program, but related, where Dr. Reininger was also working, and that was through a collective impact. And we realized that through some research and information that was provided to the group, that there was such an integral correlation between diabetes and depression. And so we found that when their diabetes was out of control and their lifestyle was having to be changed and their medicines weren't working all the time, that would lead to depression. And the depression getting worse would lead to them not caring about how to care for their diabetes. And it was just a cyclical effect. And so we very intentionally integrated behavioral health into our primary care setting. We contracted one of our psychiatrists and a behavioral health counselor to come work with us. And we started tracking, and particularly the diabetic population. So this is just one example on this slide that you will see a group of 275 diabetic patients that had A1Cs above 8. At that time, we were using 8. Their average A1C was 9.2. And so, but we also were starting at that time, it was the very beginning of our measuring their depression. And that actually has continued to this day. So what we do is every patient who comes in the door, we will have a PHQ-9 questionnaire done. And we now enter that score as a vital sign so that we have it, and we've had it now for 6 years, so that we can track and see how the patient is doing with their PHQ-9 scores. And so at that time, that same cohort of 275 had an average PHQ-9 of 5 or greater, but the average was 5 for that group. And we started having our providers, it was sort of a very, very group effort, because our doctors, we would do the PHQ-9 and we had these little cards that would be placed on our ID badges. We have this, we carry so many ID badges here at the State Center. So, but these little cards were added, and it said to our nursing and providers what to do based on that PHQ-9 score. And so if the PHQ-9 score was over a certain level, they would advise the provider. This was the nurse who would do it. If it was over a different set, if the score was higher than 10, for example, they would bring in the counselor as well as the provider and say, hey, just heads up, this patient's PHQ-9 was 10 or so or higher. If it was 15 or higher, we had the counselor talking to them even before the provider would get in. And so we were very intentional with how we did behavioral health. And what we have found is it continues to this day, because one, our providers won't let us stop. They really want us to be aware of that and be working with our psychiatrist and our counselor. And so for that particular cohort, by the end of the year, their PHQ-9s were now much better. The average was 3. And lo and behold, just like it had been foretold, the A1C was lower for that same group. And so I can't tell you which one came first, like the chicken and the egg thing, but I can tell you that they're very, very related. And so we continue to this day to integrate this process in our system. Every time the patient comes in. At the beginning, the patients were a little put off by it. They were like, I'm not crazy. There's nothing wrong with me. I'm not depressed. And we were telling them, we're simply doing this as a new vital sign, just like we take your blood pressure and your weight and your temperature every time you come in. We also want to know how you're feeling. And so now our patients will say, hey, where's my questionnaire? They haven't given me my questionnaire yet. So it's become very inherent to them. So now they're very used to it. They fill it out every single time. So it's been a really big plus for us. One of our biggest partners, though, in all of this was Salud y Vida, because like I mentioned, this all sort of started, the integrated behavioral health component was part of my visiting with Dr. Reininger and hearing the relationship between depression and diabetes. More significantly is the fact that we started knowing about other programs that our partners were working with, and one of them was Salud y Vida. And Salud y Vida, we partnered very early on and at the very beginning of the program. And it was such a strong collaboration because we found that uh, the interaction and cooperation of the Salud y Vida program with our program had such a great effect. There was no way we could do this on our own. Basically, what it was doing was it was allowing us to surround our patient with not just the primary care that we offered, but also with the behavioral health counselor, with medication therapy management, which was offered through the 2.0 of Salud y Vida's program, and then also the nurse navigator who would enroll the patient into Salud y Vida and coordinate all of the other efforts that might be needed by that patient. She would also even help us for the patient who was not quite eligible for the Salud y Vida program. So if the patient A1c was not quite high enough to be eligible for the Salud y Vida program, she would offer other suggestions that we could do with our program. So our nurse navigator was just so instrumental in being able to help us with patients. The community health workers were providing diabetes self-management education. They were providing home assessments. They were offering all sorts of coordination to the patient. We get to only touch that patient once every 3 months. And even then, it's for 30 minutes at most. And so, by us being able to have that coordination and communication coming from the community health worker about what else was going on during the time that we don't see them. They were contacting us. The nurse navigator would message our doctor through our computer system, asking them questions or letting them know how patients were doing. And that, I believe, is what really improved our outcomes on our patients because we were surrounding them with resources, and it was much more than just one visit every 3 months to come see their PCP. Whoops, I went a little too far. Let me go back here. There we go. One other component of the Salud y Vida program that continues to this day and is very, very helpful is care coordination. We have these bi-weekly case management meetings with a multitude of folks that join and talk about patients who are struggling. Hold on a second. Keeps going. I don't know what I'm doing here. There we go. That are struggling and whose A1c maybe isn't showing the outcomes that we need them to see. So in these case management meetings, there are all sorts of coordination being done. The patient is evaluated. When was the last visit? What were their last lab results? Was there anything in the home going on? So the promotores are there talking about what they have done, what information they have acquired from their intakes. And then we find out, and sometimes it's, well, they don't have transportation and they need assistance, and the Salud y Vida program coordinates that. Sometimes it's they can't afford their $7 copay for their meds that they get at the clinic. And then Salud y Vida Compassion Funds comes in and helps the patient get that. And so all of this has been such an incredible difference in being able to surround particularly the most complicated patients in a sort of a meeting setting where we get together and we talk about it and we all brainstorm ideas of what else could we offer this patient that we have access to. And so those bi-weekly case management meetings have been very, very helpful to our very complicated patients. The next slide is just a quote from one of our doctors. This is from Dr. Stanley Cowell. He's one of our internal medicine physicians, and he is so impressed with the Salud y Vida program. His quote is that many of the patients that we have here have extremely lacking in any sort of health education or support and assistance. And Salud y Vida makes a big difference in helping our people achieve their goals and their goal of good health and happiness. You know, the integration and the collaboration with partners, it didn't happen overnight. You know, this took several years of us tweaking and meeting and setting goals and trying different ways of the navigator being co-located or maybe by phone, or, you know, all these different things took time, but we never gave up. We were always assessing, evaluating, reconfiguring, go back to the table, assessing, evaluating, reconfiguring. And I don't think we're done. You know, we as a clinic have updated our policies to include many of these steps already in them, where we want to continue them and not stop. But honestly, without our partner, Salud y Vida, they're the masterminds behind the majority of the work that was done here in the transformation in our delivery of care. So I just want to thank Dr. Reininger, Dr. McCormick, Julie, all of the people involved. Thank you so much for just allowing us to have been a part of that team participating, because I know on behalf of our patients, it has been so valuable.
Thank you for being our partner as well. We are very grateful to be able to work with you and your patients. How do we measure our work? Dr. Reininger had shared slides that showed how the program is doing within the population that we're serving. How is their A1c over time? But there's another way that work can be measured, and DRPH has really challenged us to measure this way, in large part because this is how we report our metrics to our funder, HHSC, and this is the only way we can get paid, if we can show the outcomes on a larger population. When I was mentioning about enrollment, I shared that we focus on the high-risk patients. Surrounding those patients, as Mary, to use Mary's words, surrounding those patients with these wraparound services will have an impact on the clinical population. If we're focusing on those who are poorly controlled, then and then when we're measuring the whole clinic, we're targeting those uncontrolled. Those who are controlled are remaining controlled, right? Those who have their diabetes care. Their diabetes care is successful and everything is working well, then we should see that at the clinic population, everything is looking better. And so what we want to share with you here is this is a measure that we report for DRPH, and it utilizes a national measure from the National Committee of Quality Assurance, NCQA. And the measure assesses the percent of the population served by a specific entity. In this case, the entity for us is 4 clinics that we work with. So it assesses how that entity is doing with HbA1c control over time. And we have not mentioned in this call, so I will spend just a minute here on this. So anything HbA1c greater than 8 is considered poor control. Greater than 9 is really uncontrolled. So we want to be anything below 8. And what you see here is this measure reported over time since we started that shift in DRPH in 2017. And I want to start with the blue line. The blue line is how the numbers that we've reported for across all our four partners. And remember, our partners are reporting on their patients and individuals who are also their patients, but also enrolled in Salud y Vida. And so what we see is that we start at a little bit over 30% in 2017. I'm not sure if my cursor is able to move. Is everybody able to see my cursor move? No? Okay. It's just my keyboard. All right. There we go. Thank you. So the blue line starts at just above 30%, and we see slight decline in 2018, more decline in 2019. So what that's showing is poor control is getting less, right? So if poor control is getting less, then good control is getting higher. There are more people in these clinics who are achieving diabetes control. And then, of course, we had COVID, and in 2020, we experienced an increase. Now, still focusing on the blue line, I just want to mention that this measure, that is a measure that's used nationally, has a high performance standard and a low performance standard. And so the high performance standard is 29.4%. Where we are with all our partners on this is that we are very close. And in 2019, I feel like we exceeded, we did better than the high performance standard. And keep in mind, this is an uninsured population, mostly, facing a lot of barriers, many who are unemployed, even within our clinic populations. And so there are so many setbacks, yet we're still seeing this improvement. And that is a result of this clinic and community partnership that I think is really working. We pulled out Rio Grande State Center's numbers as well. So the blue line is all partners, but then we're showing Rio Grande State Center because Mary had this, she shared that connection between behavioral health and diabetes control. And so we see here really good results, and many factors, I'm sure, contribute to this lower than average, or better than average, sorry, not lower than average, better than average diabetes control. And so it's within our partners, we're doing great. One of our partners here is doing excellent. And the dotted line is how all organizations that participate in DRPH who report these numbers, the dotted line is that average across the state. And we're doing better than the state. That's a good thing to celebrate. And the red line is everybody else in this region who participates in DRPH and reports these numbers. That's the average, excluding what we report under UT Health and UT Health Science Center San Antonio. So we are significantly better than what is happening in this region across other DRPH providers. So I think this says a story that what we're doing to have this clinic and community partnership has an impact to clinical measures. It has an impact to the patient's individual health, but it also has an impact to clinical outcomes, and particularly using national standards, we are seeing an improvement. So we are now going to hear about what Salud y Vida does in the community. You may recall the model image that we showed. There was clinic, there was home, and I didn't dive into the community setting because Alma will be sharing that with us today.
Hi, welcome. And I've been very, very impressed hearing all the information we've been sharing, and to hear that Salud y Vida as an organization is doing wonderful and that our partner clinics are doing great. So we also want to hear from our participants. And I know they have a lot of great stories to share because Salud y Vida is really out there with our community, helping everyone, like you mentioned. So again, my name is Alma Martinez, and I'm here to share with you a little bit about how we are also serving our community. So we offer the diabetes management classes at partner clinics, and of course now with COVID, that hasn't stopped us. We're also offering our DSME Platicas on Facebook Live, and we're doing Zoom meetings. So we're trying our very best to stay focused and stay communication with our participants. So we've been doing self-monitoring sessions, healthy eating, reading food labels, physical activity, of course, coping with health issues. We talk about information on medications, getting them to understand and know their medications, and the different complications that come from diabetes as well. Heart health, like you all mentioned, we've also added high blood pressure. So this is very, very important information for our parents. And we work with them at a level that's very understandable. If they have questions, we stick around to answer their questions. Most of our participants have been very, very happy with our program, with our sessions that we've had for them. And here's a little bit of attendance for our DSME Salud y Vida classes that we have. Participants have attended DSME classes. 73% of them have attended at least one class. Excuse me. 50% have attended more than 6 classes. And then also we're happy to announce that even after they've completed all the required sessions, they continue to come because they like the support that the program provides for them and the knowledge that they gain. Sometimes they may have forgotten, it's been a year since they've been to the classes, so they're able to come again. And we also invite or have them invite family members that may be able to help them understand. One of the things that we like to also talk about is that we're there at the community centers with our partners so that other people that may not qualify, as you mentioned, for the program, they can still come to the classes and sit and listen and get that information that they need. So it is open to everyone. So here's a little story that you're going to get to see in the video about Christina. And like I mentioned, we heard about your community leaders, the program leaders, the partners, and now we want to hear from our participants as well.
¿Cómo le ha ido con usted con su nutrición?
Ay, bien, gracias a Dios. Con Salud y Vida pues me ha enseñado bastante. Yo mi A1c estaba un 9.4, ahorita ya está un 5.8.
Un aplauso porque
Mi nombre es Cristina Peña, estoy con Salud y Vida desde mayo a ahorita. En mayo yo pesaba 317 libras, ahorita peso 272 libras. En mayo mi A1c era un 9.4, ahorita está un 5.8. Salud y Vida me ha ayudado bastante en cómo comer, cómo tomar mis medicinas, cómo checarme mi glucosa, muchas cosas me ha ayudado Salud y Vida.
Nomás porque tienen todos diabetes, su azúcar no va a salir exacto los mismos números, ¿verdad?
No.
Lo que vamos a hacer es, puede ser algo, por ejemplo, que a Jesse le sale bien, vamos a decir que le sale 150 o 160, ¿ok? Él va a saber que cada vez que come esto le va a salir bien. Pues vamos a decir que a Cristina quizás esto le va a salir a 200, porque le salió bien ok, ahora ella va a decidir qué en este plato está subiendo el azúcar.
El programa te enseña los modos cómo comer, pues cómo checar las etiquetas de los botes, cómo checar muchas de las cosas que uno debe de comer, no comer lo que no debemos de comer. Los cambios que yo he hecho es antes comía afuera mucho, comía cosas que no debíamos, ahora con Salud y Vida me ha enseñado a cómo comer saludable. La porción, yo me hago una martilla de las mañanas con mitad de fruta que es papaya y la leche de amelia. No más que sigan con Salud y Vida porque sí les enseñan cómo comer realmente y cómo a seguir su salud.
So that was Christina's story. Isn't that wonderful? And we have many other participants who also have shared and done videos for us about how they've really improved their health through our program. So this is what she was saying, that she had uncontrolled diabetes, but with the help and support of Salud y Vida, she has improved her A1c, has learned to control her diabetes, and has learned many things like reading food labels, making healthier food choices, and checking her glucose regularly. She even lost some weight. I know she mentioned that she started at 317, and right now she's at 270. That's about 40 pounds she's lost. And she continues to do our DSME classes, although I think she has graduated from the program. She continues to view the classes online for support. That's something that shows a lot about what the program does and how it helps everyone. Here again, her A1c at enrollment was a 9.4. She was low self-efficacy, had some depression. She was not very easy to engage. She's uninsured. And then she, at her 9 months time point, community health workers have visited her, have helped her improve her efficacy, have helped her retain in the program. And she, like she mentioned, she has learned so much about the program. Here's her story again, a little bit about stats and what it looks like on a graph. And that looks very impressive, including her weight loss there. She's very happy, and of course, we're very happy to have been able to help as many participants
have. Wrap up with showing you just the cadre of amazing partners that have, that we work with, that challenge us, that lead us, that inspire us to make a difference for the patient population. You can see we've got clinic partners, we have nonprofit organizations, Southwestern Medical. We want to recognize Dr. Lee, who does a lot of our analysis on the Salud y Vida data. We have great partnerships with the Tu Salud 50 program, because now we're referring participants to exercise classes that are offered through the Tu Salud 50 program. So you can see the various clinics that we talked about today, the Tropical Texas Behavioral Health. We can't say enough about the partners, and we also can't say enough about the Salud y Vida team. Amazing people, amazing dedication. It doesn't happen without this group of people, right? These results are because of your work. So we're celebrating you and the efforts. It takes a lot from our data team, coordinating, sharing information, making sure that that we have active, up-to-date, timely information. The outreach team, who is, from the time they walk in the patient's front door, where we're assessing behavioral health, assessing a number of other factors so that we provide accurate information, referral support, and then all of the management of the finances and the purchasing and the tracking of information, making sure that we have accurate information to analyze, and all of us, under leadership with Dr. McCormick, we're making things happen. So what a terrific team, and I wish I could say even more, right? But Lisa Payne, Lisa Mitchell-Bennett, Juliana Lopez, Maria Zolezi, thank you for your efforts. So we're going to pause there. And we would love to open it up for questions, comments, ideas, etc. So. Got a few. I can see my chat. So shout out to all the community health workers who are the heart of the program, right? To your ability to relate to people, your peers, build trusting relationships. deliver services in the homes of participants. Great job, right? Great job, great partnership. We may, I don't know, Obed or Myra, if we may need to unmute folks so they can, or if they have control, but does anybody have any questions or comments? I do also want to mention that, you know, the outreach efforts, we have this incredible organization, Proyecto Juan Diego, who has worked with us to provide the same, like we just run in parallel, right? Doing the outreach, participating in case management, the review meetings, every aspect of it. We would not be able to do this program without Proyecto Juan Diego as well. So again, another shout out. I know I'm never gonna be able to say enough to cover everybody.
So Dr. Reininger, I just want to make a few comments. Regarding the issue of depression and diabetes, and another part of this team, in some ways, the clinical research unit folks, who also go out in the community and bring people in, and they can ask questions and get answers that most of us could not. One of the things that we looked at and actually published several years ago now relates directly to the issue of depression and diabetes, because we learned that if people knew they had diabetes, and we actually measured at the time they told us they had diabetes, they were likely already depressed. They were already likely had a score that would indicate some level of depression. If they had diabetes, but they didn't know it because they came into our clinical research unit, said, no, I don't have diabetes. And then we showed, in fact, based on their HbA1c or their blood sugar that they did, they were not depressed. And what that really said, and we worked with Dr. Renee Olvera, from a psychiatrist who is from Brownsville, but he's at UT Health San Antonio. We published this to show that if you make a new diagnosis of diabetes, then you have to plan on the fact that somebody's going to become likely to become depressed. And then with another study with MD Anderson and Dr. Olvera, we showed that if you are depressed, you are much less likely to control your diabetes, to have effective self-management. So that's kind of at the heart of all of this co-location, I think, of and paying attention to depression and diabetes. They certainly, just like depression goes along with cancer and heart disease, a lot of other things, it also goes along with diabetes. So it's really been a very important part of this program. Another part that I want to mention that I think allowed us to grow this program was our decision of now 2 or 3 or 4 years ago to start doing eye screening. There's nothing worse than somebody going blind because they don't get treatment and management of diabetes. It's one of the worst outcomes you can have, that and having an amputation. And so having the ability then to get started to show that we could, in fact, screen for eye disease in diabetics and then refer them, I think that idea has now grown. And so Baylor has now come into that space, and they're helping to do eye screening at Brownsville Community Health Center. We're trying to start this at PJD, but they're now reaching out to Tropical Texas and to Nuestra Clinica over in Hidalgo County to help with improving and enlarging the eye screening. And now Dr. Reddy, one of our ophthalmologists in the city, in the Brownsville, and working with BCHC, is actually setting up a clinic where they can start treating people who we can't otherwise get treatment for eye screening. So this Tu Salud y Cuenta program now is having all sorts of ripple effects, if you will, for efforts to address other issues, important issues, associated with diabetes and chronic disease management.
Dr. McCormick, for covering all of that. It really is so impressive that we were able to build something so holistic, and then yet we continue to find ways to have even greater impact and reach into those with special needs, and do something meaningful for them as well. So great comments. Thank you. Other comments, questions? Right. Then I am going to do two things.
I want to give out, I just like to add my shout out to not only all of our partners, obviously, but our great team. I think there's no way, you and I have discussed this many times, without such really talented, hardworking, smart people, we would never be where we are with this program. And that includes our partners like Mary and our programs at the other clinics. So I just want to add my thanks to everyone for this outstanding program.
Well, and Dr. Reininger, just so that you know, I have this stuck to my workstation, and it is such an example of exactly why things work out so well. So this is what I remind myself of every day.
Nice. With a common purpose, we can do so much more. Absolutely. Yeah.
And thanks to your leadership and the program there, it's definitely being accomplished. So thank you again.
Yeah. So, Mary, thank you for making time and sharing your story. Julie, thank you so much for all you did to put the presentation together and show the great work we were doing, but also for your leadership every day. And Alma, thank you for the amazing work you do to coordinate the education and make sure that what our message is on the front line is accurate and impactful. I'm feel very honored to have presented with you all today, and to see all of these names of people who have made such a difference. Thank you for attending today. I'm going to do a shameless plug. So forgive me for this, but you're going to be seeing an email. I'm trying to get it so you can see it here. Sorry, I'm going to share it. That's going to come out, and it's talking about our legacy with the School of Public Health and our work in our 20th year to raise money for scholarships. And you're going to see we're doing a crowdsourcing effort, which we've never done before, for our students. And so as a way to celebrate our 20th anniversary, we're wanting you to help us spread the word. And it can be a donation of $5, of $10, of more, if that's something you're willing to do, to make a donation specifically to a scholarship for our students, for students from the Rio Grande Valley. So you'll see this email come out, and I just want to encourage you to share it, right? Not only think about it for yourself, but also just to share it with others. We feel like, the way we can have this future, our next 20 years, right, is to continue to grow public health professionals and professionals who understand the magic that happens through partnership and a common purpose, as Mary said, and result in programs like Salud y Vida. So I thank you all for attending. We're going to give you back 9 minutes of your life. And we, again, thank all of you for the work you do. Bye, everybody. Thanks for joining.
It's right here. What did you mark? Yeah, what he marks, what he decide.